no shortage of awareness these days on the topic of wellness related to medical students, residents, attendings. The entire life of a physician has really changed dramatically. A lot of it sort of coincides with the advent of the electronic medical record, but it's changed the way people interact. I think our M&M this morning illustrates one such example of that it's just depersonalized a lot of what we do. And it's important because our physicians are the core of the healthcare resource. As somebody else said, otherwise we just have a big nursing home we're running. So it's important that we pay attention to these issues. So I'm really proud, for those of you who don't know, that Dr. Karani has agreed to serve as our sort of departmental wellness champion and represents us in a lot of the organizational issues that are happening across the institution, as well as working with Dr. Cook, who is our vice chair for faculty development and wellness as a team to help deal with these issues in the department. And she was brilliant in making the suggestion for today's grand round, and I'm going to have her introduce our guest speakers. So thank you, Dr. Khan.
Thank you, Dr. Farmer. Good morning. So I'm really pleased that today we have Dr. Peter Yellowlees, who is our Chief Wellness Officer for UC Davis, and Dr. Aileen Wetzel, who's CEO of the Sierra Sacramento Valley Medical Society. I've had the pleasure of serving with them on the UC Davis Health and Physician Wellness Advisory Board, as well as participating in the inaugural class of the Physician Health and Wellbeing Fellowship, along with Skeeter and Maggie and Amanda, run by Dr. Yellowlees. It's been really educational and eye-opening so far, realizing how little we really understand about these problems. From day one of fellowship, I didn't even know that physician wellness and physician well-being were two entirely separate words. So I've been asked a lot since I've been given this position, what are the solutions? And I think we're working to understand exactly what the problems are specific to our department. But I'm really glad that Dr. Yellowlees and Dr. Wetzel could be here today to talk about what a high priority this issue is for both UC Davis and the region. And they have a lot of innovative programs that it's important for us to know about. Thank you.
Good. Well, thank you very much indeed for inviting us both to come here and talk. And I must say it's a real pleasure to be here among you. I'm going to kick off by asking all of you a question. Who here, put your hands up, everyone who knows of either a student or a physician who has suicided? Okay, so that's about 2/3 of you. That's pretty typical for medical audiences. And the reason I start off with that is because this talk is really relevant to all of you. And it's really important that you think about the content of what we're going to talk about. It's very easy for people to think of this as a soft topic, and it really isn't. Because the fact is 2/3 of you actually know someone who's gone down a very unfortunate path and eventually suicided. And that, of course, from a physician's perspective, is really, the absolute last thing we want to happen. So I'm a psychiatrist, and I've treated physicians as patients for many years now. Rather than tell you lots of stories about them, what I thought I'd do is just summarize the two things that I have really learned about physicians as patients, okay? Because we're all patients as well as being all physicians, okay? So there's two things. One is that physicians really don't like to admit they've got a problem. Does that surprise anybody? Okay. There is a huge amount of denial. We prefer to manage on. We've been trained from day one in our medical school to know that every problem is solvable if we just work harder. And so we have these attitudes that make it very difficult for us to actually accept help when we have problems that we're not resolving ourselves, okay? So that's one thing that I've learned. And so that's a lot of what Aileen and I are going to be talking about today is about getting better access to care for physicians who need it, okay? So the second thing is that when physicians actually do get into treatment or do get help, they do incredibly well. And in fact, a lot of those suicides are totally preventable. Had those individuals got into care, got some assistance in whatever way, lots of different approaches. But for me as a psychiatrist, treating physicians is a pleasure because physicians do really well on the whole. I mean, there's a few difficult people, okay, we all know that. But the reality is the majority of physicians want to get better. They're quite actually adherent to the treatment process. They develop insight and they actually make big changes and can really turn their careers around. And so it's very rewarding to treat physicians. So think of those two big things. Difficult to get into care, but once you're there, you tend to do really well. And in fact, the outcomes for physicians with substance abuse, for instance, are remarkably good. There's been a couple of big studies now looking at the long-term outcomes of physicians who've essentially virtually lost their medical records, their medical licenses, had to go into forced treatment programs. And at 5 years, 80% of those physicians from all disciplines were still working and still with their licenses. Now, I can promise you, as a psychiatrist who sees people with substance abuse, if I had an 80% positive 5-year success rate with all my patients, I would be ecstatic, okay? So physicians actually do well. So I guess the message for all of you is don't be afraid. If you think you or a colleague needs some help, actually make sure that they get it. So, quick disclaimer, I've written a couple of books on this topic, both of which are underpinning a lot of this talk. One of them on suicide was published last year. The other one on well-being is being published around Christmas time. There's two learning objectives I'm going to present. The first is just very briefly the broad epidemiology of the types of disorders that physicians have. And secondly, I'm going to talk about the UC Davis perspective and what we're trying to do here. Aileen, who I work very closely with at the Sacramento Sierra Valley Medical Society, is then going to talk about the regional level and how we can collaborate as a medical center and a health system with the medical society. So just to put up the names of all of your people who are involved in this area. Obviously, Dr. Karani has been crucial, Dr. Hediati, a number of other departmental champions from other surgical specialties, and of course the 4 people who Dr. Karani mentioned who are taking the fellowship program. And I'd certainly welcome more to the next fellowship program starting next April. Now, if you look at physicians and their overall healthcare, physically we're actually pretty good. We tend to live 2 years longer on average than a similar age-matched, education-matched group of people. So we actually do physically okay. We tend not to be morbidly obese, we tend not to smoke, we tend to get a reasonable amount of exercise, and physically we're actually pretty good. From a psychiatric point of view, we're not good. We're not as good as sort of general matched populations, which may be surprising because we actually start off really well. And if you look at studies of medical students, they actually are more resilient and have less burnout than other graduate students. So we actually all start off really well. We've often gone through a very hard process to get into medical school. We're highly resilient, highly effective people, and something goes wrong over the next 10, 15, 20 years. And my thesis is that mainly this is an organizational issue. And it's mainly organizational changes that actually impact us as very resilient people and cause us to have more problems than we should be having. So what are the differences in terms of mental health and the general population with physicians? First of all, there is an excess number of suicides among physicians. About 400 physicians a year, approximately, we don't know the exact number, die from suicide. And this is in equal levels from a gender perspective, so males equal female. The general population, a lot more males kill themselves than females. And these are proportionately more suicides than you'd expect in the general population. The second big difference is that a large number of US physicians suffer some symptoms of burnout. Some studies suggest between 50 and 60%. And the third big difference is our substances, okay? We're fairly traditional. We tend to stick to booze. Occasionally we get into narcotics or benzos, but we're not terribly keen on meth or cocaine. And so we're different from a general population in those three ways, all right? Apart from that, we have all of the other same mental health problems that the general population has. Now, one of the issues that I feel very strongly about is this issue of professionalism, because I say it's an organizational issue that causes us to have these problems, primarily. And there's a lot of very good things about professionalism, about the ethical principles that underline what we do, how we train ourselves, how we have a sense of higher calling. That's all great. There are, unfortunately, a lot of unintended consequences of professionalism. The first and most important thing, quite honestly, is lack of time. We tend to obviously overwork as a profession. There's no question about that. So lack of time, particularly for self-care, for our families, for our friends, for our loved ones. We tend to be very good at denial, particularly when we're confronted with traumas. And we're often confronted with traumas. That's part of our clinical lifestyle, okay? And we tend not to, in fact, take the time out to try and work through those or even acknowledge them. We tend to be very self-reliant, which means we often try and treat ourselves. About 30% of physicians, for instance, don't have a primary care doctor. And we should all have primary care doctors. And then there's a whole lot of issues around embarrassment and fear of having a psychiatric disorder or depression or anxiety, something like that. Now, there are 5 main sets of health issues. I'm not going to go through them all in any detail, but essentially, you think about burnout, our high levels of that. Disruptive behavior is behavior by people who are essentially too arrogant and a bit antisocial. And they tend to be people who are not popular with their colleagues. There are issues around aging and how do we make sure we catch the experience and the positive side of more elderly physicians, but at the same time, they have to learn to retire. And a proportion often get cognitive impairment. We don't have a good way of almost trying to help people move out of a profession, perhaps by taking over, stopping clinical work, doing more educational work, things like that. All of the psychiatric disorders and substance use disorders that the general population has as well. So if we look at burnout very briefly, 3 sets of symptoms. Emotional depletion, which is basically being tired. Detachment and cynicism, where you start thinking you don't care about your patients anymore, you think of them as numbers. And a sense of low personal achievement. Why did I even get into medicine in the first place? What's the point of this? Surely I could be working somewhere else that was better. The grass is greener on the other side. So these are the major symptoms. Who gets burnout? Well, there's been lots of studies of this. For surgeons, if you look at their results across multiple studies, they essentially have moderate burnout levels, slightly more than average, but low satisfaction with work-life balance. I'm guessing that's not a total surprise, okay? But that's the sort of conclusions. The interesting group is neurosurgery, which is a real outlier here down at the bottom, with essentially a moderate level of burnout, but absolutely no work-life balance. So these are important things to think about. Now, what causes burnout and what's the effects? The causes are simple. High workloads, workflow inefficiencies, such as you were talking about with the M&M, increased time spent on documentation. I've never met a medical student who said they wanted to come to medical school to learn EPIC. Okay? It's as simple as that, all right? And so it's a pain, all right? We have to use it, but we've got to learn to use it better. And then the effects are a loss of meaning of work, a social isolation, and it's very importantly, a cultural shift from health values to corporate values. And I think that's where you can blame a lot of the lack of medical leadership, quite honestly, over the last 20 or 30 years, with corporations increasingly taking over medicine. And I think we need to get that back. So what are the impacts of burnout? At a personal level, broken relationships, alcohol abuse, depression and suicide. At a corporate level, and this is how I argue with the corporate leaders, we know that burnout causes decreased quality of care, more medical errors, decreased patient satisfaction, decreased productivity, and increased turnover. These things are all really expensive, and they're really important. And so, that's why every department is creating well-being champions, okay? These well-being champions are not going around teaching you yoga, okay? That is not the aim, all right? What I want them to be doing is making sure that the EMR works better for you guys, that you have less time spent on, quite honestly, often ridiculous and useless administrative tasks, things like that. So, internally, the model I'm using is the one that Stanford has developed, thinking about 3 areas for change. The first is to create a culture of wellness within the health system. Secondly is to make our practice more efficient, in other words, so that you have more time to get home. And the third is improving personal resilience, which is actually the least important of the 3, because as I say, physicians are pretty resilient people from the beginning. So some of the things we're doing for the culture of wellness, we're trying to essentially develop policies, practices, procedures that actually make it easier for people who, if they wish to get care, can receive care. So they can access care, access assistance, access counseling, access support, whatever way it is. So ways that everybody can access care. And us doing this Grand Rounds is part of that. It's actually to tell you about these sorts of programs. We're obviously looking at data. I've actually got an informatics background as well as psychiatry. I'm very into data and IT and stuff like that. So we're in the process of creating a well-being dashboard that all the chairs will have access to. So you don't just have a dashboard of how the hospital's working, you have a dashboard of how the physician group is working. And I think that would be really useful. We've talked a bit about some of the teams we're developing across the whole system and the individual wellness champions. A lot of communication. Most of you have seen the good stuff emails that I send out every Tuesday. And we're very heavily into collaborations, hence Aileen and I talking together today. So in terms of accessing care, the wellness survey. This is a self-assessment survey. We've been doing it for 5 years now. It's available to all of you. It's completely anonymous. You can go on and risk stratify yourself for essentially anxiety, depression, substance abuse. And if you want, you can reveal who you are. If you don't want to do that, you don't have to. But you'll get a response from a PhD psychologist who will give you hints and ideas as to what to do, and if necessary, can refer you into care. We have referred over 80 of our faculty and residents into treatment through this survey in the last 5 years. So that's more than 1 a month from our single practice here at UC Davis. That's really very impressive. These are all people that wouldn't necessarily have got referred in other ways. We have a very specific referral pathway if somebody is thought to be impaired. The training directors, chairs, all are well aware of this and can assist. And so we have a process that Nassim is heavily involved in through the Wellbeing Committee, whereby we assess our own people and get them into treatment and monitor them to ensure that they're safe to practice. This is good stuff. Incidentally, on good stuff, send me notes about that. Send me people you want calling out. Okay, I want to, get your names in there. If there's something you want to have me talk about, tell me, and I'll work out how to actually the actual the written component with that person. But send me their names. So looking at the efficiency, there's a number of these different areas. We're really looking at the EMR in a big way, working quite closely with the PEP team, which is a sort of physician efficiency program. It's a horrible name, and we're trying to think of a better name for it at the moment. And then eventually we'll be developing metrics for all of leadership on this area, so that provider wellness is seen as being one of the major aims of the health system, not just patient wellness and patient outcomes. Now, thinking about the EMRs, there's a whole lot of ways we can improve documentation. There actually is some very interesting changes from CMS coming up. And the AMA has just produced a nice little learning module here looking at how we're going to be able to reduce outpatient documentation by, from 2021, taking away the need to actually get those sort of 15 scores for 99213, which is just crazy baby stuff, and move to a process where we just have to do medical decision making and time. That will potentially save a massive amount of documentation time. We've got several physicians working on that right now to look at how do we improve our notes. There's a similar process that hasn't been formally announced yet for about the 50 most common procedures, things like lumbar punctures. So that if you do a lumbar puncture and it's normal, we're hoping to have literally a 1 or 2 click process rather than having to write the entire thing out, okay? So potentially quite a lot of ways of improving documentation and really saving time. I'd encourage you to all get into telemedicine, okay? Now that may sound weird because you're all really into operating, but the fact is you can see your patients before and after on video. We mandate this for all the psychiatry residents now. They're all doing it. What happens is that they actually save a lot of time. They're seeing the patients, and when you're seeing patients on video, it's socially appropriate to type your notes at the same time. The patients can't see you typing away, you just type away. I do all my notes as I'm seeing a patient, save myself a lot of time, and actually make the actual consultation more efficient. Clearly the patients like it because they can see you from home. So this is an efficiency process, and think of video visits as being an efficiency process from your point of view. And then finally, personal resilience. There's a whole lot of things that we're doing. Hopefully, most of the attendings here have been to the physician lounge. There are equivalent lounges being planned for residents. But we're also developing a lot of educational programs. Dr. Kirani talked about the fellowship program. I think we've got 17 fellows doing in the first batch this year. We've already got 20 applicants for next year, starting in April, all from outside our system. So I want to have a few applicants from inside our system. The other thing about personal resilience that's important is there is a real connection between your physical health and your mental health and your patient's physical and mental health. And this has been studied. So physicians who look after themselves better tend to teach their patients the same tricks. So think about your own health as actually being good for your patients, okay? Not only because you're healthy and you can turn up to work, but because you're going to pass it on. Very important. And finally, to finish off, we've got a physician healthcare summit coming up on November 13th. You're all very welcome. We're going to have a series of presentations from a number of our departments. Tate Shanafelt's coming from Stanford. He's the sort of guru of burnout in the country. And then I'll be summarizing what we're up to. So I'm going to finish at that stage and hand over to Aileen. Thank you.
Good morning. Can you all hear me okay? Yeah. Okay, great, fantastic. Thank you, Peter. I'm going to talk a little bit about some of the things that we're doing here in the region, in Sacramento. And one of the things that our medical society is really proud of is our partnership with UC Davis. We've also partnered with the other health systems and medical groups in the region to address the issue of physician wellness. And a little bit about us, you may or you may not know it, but everybody in this room is actually a member of the Sierra Sacramento Valley Medical Society and the California Medical Association. Earlier this year, Dr. David Lubarsky saw what we were doing in the community in this area and in other areas, and basically is sponsoring your all's membership in our organization. So thank you to him for that. So what that means for you is that you are part of an organization that has been around for 150 years. We just celebrated our 150th anniversary last year. And the main focus of our organization is obviously advocating for physicians and the patients that you treat. And how we do that is through our various programs and through our various services. But I do want to point out in our mission statement, a few years ago, our board had a retreat, and it used to say that we care for the physical health of the entire community. And one of the things that the board felt really strong about is that we put the mental health of the community and of the physicians that we serve. So that's really been our mission over the years. A little bit about Joy of Medicine. So Joy of Medicine is a program that everybody in this room has access to. In fact, every physician and medical student in the Sacramento region has access to these services. You need not be a member of the medical society to access those services. So back in 2017, we were hearing a lot about physician burnout, physician wellness, and what we decided to do as a medical society is to actually do something about it. But we didn't want to go about it in a vacuum. So what we did is we pulled together the chief wellness officer or equivalent of all the medical groups in the Sacramento region. And we got together in a room and we basically created a program that is community-wide. And the program that I'm about to tell you about is actually, in the 3 years of its existence, or two and a half years of its existence, is nationally recognized. It's one that I spend a lot of time, and my staff spends a lot of time really kind of educating other medical communities about how to implement their own program because we've been so successful here in the Sacramento region. So Joy of Medicine, our efforts here in the Sacramento region, and I'm going to share with you a little bit about the successes that we've had in working with physicians individually, but really the big goal that we're gearing towards is systemic change. Peter said earlier that, and he hit the nail on the head, that we can work on individual physician wellness and resiliency till the cows come home. Yoga, meditation, wellness, all that sort of thing. But if you're thrown back the very next day into the system with the burdensome EHR, with the burdensome requirements, you're going to be right back to where you started from. So the goal of our program was really to bring those systems and those medical groups together and figure out what physicians like you want to see from their systems in order to thrive and to be healthier. So our program, I'm going to go over each of these very briefly. If you want to see more about the programs, we do have a website. It's joyofmedicine.org that you can access. So the program components, we have an annual summit, resiliency consultations, physician peer groups, promoting collegiality, an online wellness center. We have a podcast that we've launched, and then we're currently in the process of doing research. So a little bit about each of those programs. We do have our annual summit, which is coming up in September. You all are invited. It is going to be held at the Clooney Center at McKinley Park, and it's free. There's CMEs that are provided with that. It fills up very fast, and we've just released this. So if you're interested in going, I would really encourage you to go onto the website or to call the Medical Society and reserve your spot. Again, it's free. And some of the speakers that we have coming to talk about are, the positive psychology for physician health. And we had a lot of requests from our physicians to talk a little bit about the merger of physician wellness, medicine, and spirituality. So Dr. McCrimmons is going to talk a little bit, and it's not religious, he's going to talk a little bit about spirituality and how he works that into his particular practice. He's a pediatrician that has been in practice in the Sacramento region for a long time. And we're going to have all kinds of goodies that are there, and we're kind of ending it with a walk with a doc through the Rose Garden. So hopefully you all can join us. This is our third annual summit, and it's always been a lot of fun. Free CMEs. Resiliency consultations, this has probably been the most popular and well-received service that we provide. So what we make available to every physician, resident fellow in the Sacramento region is up to 6 lifetime visits with one of our vetted psychologists or life coaches. And it's entirely confidential, it's entirely anonymous, and available at no cost to everybody in this room. We feel that wellness is so important that we went out there and we raised the funds and got grants to be able to pay for these services. So the folks that you see up here are our vetted psychologists and our life coaches. If you just want a checkup, or you just want to check in with somebody, or if you have some deeper issues, you can confidentially contact them directly. You don't have to go through me or through the Medical Society. You can go onto our website and call them or email them, and you will have access again to 6 sessions sponsored by the Medical Society. And how that works is I have no idea who you are. I have no idea who's accessing this program. I get an invoice at the end of every month from each of my providers here, and you're identified as patient A, patient B, patient 1, patient 2. So I have no idea who's accessing these services. I would really encourage you. This is here for you. And if we get to the point where we're getting more folks accessing the program, then I will continue to build it. This is very important. I've heard from physicians who have accessed this program, including some former board members at the Medical Society. One that called me and said, Aileen, I just want to thank you. And I'm like, well, what did I do? He said, well, I remember when you were talking about joy of medicine and having these services available, and I never thought that I would need to access those services. He's a surgeon. Empty nester. His kids went away to school, and he felt that he really needed to access it. And he's very proud about that and talks about that. So to date, since we have launched this, we have had over 220 sessions, 80 plus, and actually the number now is just about 100 physicians in our community have access to the services. So please keep that in mind. If that's something that you would like to utilize, it is available to you at no cost. Peer groups. This is something that is super fun and has really grown much to my pleasure. So what we do at the Medical Society is we identify physicians in the community that are willing to open up their home to a peer group. And we have peer groups now in 5 different areas. We have them in Elk Grove, we have Davis, we have Carmichael, El Dorado Hills, Newcastle out in Placer County, and we're adding additional sites as we speak. And these are something that are available to everybody in this room. You can just call the Medical Society and say, hey, I'm interested in the one in Carmichael, and we'll give you the address of that physician's home. Obviously, we don't put the physician's address on our website because we don't want everybody showing up. Staff is not there. I'm not there. They are moderated by one of our vetted psychologists or life coaches, and it's basically an opportunity for physicians to get together and have some camaraderie and to talk with your colleagues about some of the challenges of being a physician and some of the successes of being a physician. And a couple of the peer groups have turned into some really, really fun groups. The one up at the top is our one out in Placer County. That's Dr. McKeeve, and Daniel Rockers is one of our psychologists. Every month they do a cooking or something around making pizza, carving pumpkins, or what have you, and they talk about their day and they talk about being a physician. And one of the things that I'll point out about the peer groups that I think is really important, and one of the reasons why I really encourage physicians in this region to engage in them, is that this is an opportunity to meet physicians that are outside of your UC Davis silo. Every group includes physicians that are either in solo practice, they may be affiliated with Sutter, with Kaiser Permanente, they may be affiliated with Mercy Medical Group, Dignity. So you're seeing a mix of physicians. And we have heard from the doctors that they really appreciate that because sometimes you just kind of want to get out of your UC Davis silo and meet physicians that are out there in the community. The sessions and the locations, again, on our website, joyofmedicine.org. We do a lot of events that, again, I would encourage you all to attend if you are able. We push them out via email, so hopefully you all are getting our Medical Society news. It's our e-bulletin that comes out. If you are not getting it, please come see me or Megan in the back of the room, and we'll get you added to the distribution list. We do things like family nights. Obviously we saw Toy Story. We rented out the theater. To do that for a chance for physicians, young physicians with families, to bring their kids and really get together and get to know each other, and various other events throughout the year. Our online wellness library is kind of a catch-all for all things related to physician and medical student wellness. You'll find things on there from books to videos to articles. We scrub it almost daily, so you will see new and refreshing data that comes on there. There's also a whole section on humor, because I personally feel, and hopefully many of you feel, that humor in medicine is an absolute necessity. You got to be able to laugh at yourself and some of the situations that you run into. So if you like Z-Dog, there's a link in there to the Z-Dog videos, which can be super fun. And then all of our events are listed on there as well. One of the things that we have recently started that has been very popular has been our Joy of Medicine on-call podcasts. And you'll probably recognize Dr. Yellowlees there. He is our host for this season, for season 2, and has been interviewing physicians throughout the region about why they got into medicine, what brings them joy. At one point last year, we interviewed an orthopedic surgeon who's in private practice who became a physician, but he didn't start out as a physician. He started out as a whitewater rapid guide and broke his bone going down the river on a rock, and decided throughout that whole thing that he wanted to be an orthopedic surgeon. And so that's how he got into medicine. We had another episode where a couple of our physicians, young female physicians, were talking about some of the challenges of being a parent, being a young parent, and also being a physician. So this is something that I would really encourage you to take out your cell phones now. Okay, how many of you have been to a lecture where you've actually been encouraged to take out your cell phone? Take out your cell phone, and you can actually scan this QR code, hopefully from where you are. That will give you direct access to the podcasts, or you can download it on iTunes or any of the programs that you are following. Did everybody have a chance to snap that? Awesome. Okay. If you missed it, it's on our website. So I want to talk a couple minutes about a very important survey that we recently completed. One of the things that we wanted to tackle in our Joy of Medicine program, I mentioned the systemic issues. So what I just described to you are some of the things that we're doing for individual physicians and for families to help, create collegiality in the Sacramento region. What we did last fall is we actually did a community-wide physician wellness survey. And I'm going to share with you some of the results, because some of the results are surprising, some of them not so surprising. So what we did is we surveyed physicians in the 4-county area, so Placer, El Dorado, Sacramento, and Yolo counties, all part of the Sacramento community. And it's the first community-wide physician survey of its kind. So typically, like UC Davis, for example, will do their own internal wellness surveys, same with Sutter, same with Permanente, and so on. What we were interested in, since we represent all physicians, including those in private practice, we were really interested in finding out how to kind of taking the temperature of the entire community. But more than that, not so much interested in measuring burnout, okay? Because we know you guys are burnt out. We don't have to ask that. We know that. So on the survey, there were 2 questions related to burnout. The rest of the survey really kind of solicited from physicians practicing in this region, what do you, doctor, want to see from your medical group and from your health system or from your medical practice? What changes do you want to see in order to help you be well, in order to help you thrive? So we got our answers back on that, and we recently shared them with each of the medical groups that were participating. We were able to drill down into their individual responses. But overall, the response, we had about a 12% response rate, which those of you that know surveys, that's actually pretty darn good. Particularly when you're talking about physicians. And the respondents really kind of mirrored what we have in the region in terms of specialties. The vast majority of those that responded were primary care, although we did have high responses in emergency medicine, psychiatry, radiology, and we were almost split evenly between male and female. So what are we doing well in the Sacramento region? What our doctors are telling us out there, what you are telling us, is that there's some positive things that are going on in the community. Generally, physicians, 71% felt okay or pretty content with workload and job demands. Cultural values, that question was really around, do you relate to or can you identify with the cultural values of the organization or the medical group or the hospital that you work within? About 84% of physicians agreed with that. Compensation, 72% were okay with that, and then social support is coming in at 65%. Now, areas where we kind of identify as the key drivers of burnout and areas that we need to work on as a community are a lot of the things that Peter referenced in his talk. We need to do better on work-life balance. Only half of physicians practicing in this region felt that there was an appropriate balance between the two. EHR efficiency, We need to do something about that, not just here at UC Davis, but at other medical groups and health systems as well. Control and flexibility was an important theme, and then also a sense of community. Feeling that you're part of the medical community in the Sacramento region is something that physicians wanted to see more of. So the overall burnout question, and this was really interesting to me and was surprising to me, and it may or may not be to many of you. So you hear a lot, you read JAMA, you read all the periodicals, and all you're reading about is physician burnout and how burnout you all are, right? Well, the national statistics are that over 50% of physicians routinely report that they're significantly burnt out. What our survey showed is that there is a level of burnout in the Sacramento region. However, our burnout rates in the Sacramento, where folks came in positive for burnout, is about 35%. That's significantly lower than the national average. And that's telling me that physicians that are practicing in this region are generally happier, generally more content than your peers in other parts of the country. So that's something to really celebrate. I think that a lot of what we're seeing with the chief wellness officers really kind of promoting wellness on their individual campuses and within their medical groups is beginning to make a difference. So some of you may or may not agree with that, but that's what the survey numbers are telling us, so we think that that's good. We think that's a reason for, especially those of you that are residents and fellows, why you need to stay and practice in the Sacramento region, because we're happier than other parts of the United States. I'm going to skip over that. So some of the specific recommendations that we had coming out of the survey, we published this in a white paper, and it's available if you go on to either ssvms.org or joyofmedicine.org. You can download the white paper and take a look at it. We published it last month in July. And it's actually been well received by folks. No big surprises here. What physicians were telling us specifically, we knew that EHR was a pain point, but we asked, what changes do you need to see in the EHR, or what can be implemented in order for you to not feel so burnt out or pressure and anxiety around the EHR. And what physicians in this region specifically told us that they want it to be more efficient, user-friendly, but how do we do that? The majority of physicians responded that what they would really like to see is in-person scribes, voice recognition software, and then personalized EHR training. And what I mean by that is, Peter put up the example of him seeing a patient and 3 screens going on and really being able to have eye contact with the patient. Well, nowhere in that is the patient able to see the computer in the EHR that you're working off of, being able to take that out of the equation so that you can have that contact with the patient. Those are all things that may be different for a surgeon, may be different for a family practice doctor, may be different for somebody else in another specialty. But the idea here that we're trying to promote to the health systems is you need to devote time to have IT specialists meet with physicians, individualize their experience with the EHR. Look at some of the shortcuts that make it easier for that physician, or for that specialty for that matter, to be able to use the EHR. So that's something that we're really promoting at the Medical Society, and I know that UC Davis has embraced many of those approaches. The other recommendation on the work-life balance, the number one thing that doctors in this region wanted is more flexibility over their schedules, and assistance with administrative tasks, help with their inbox. A lot of time being spent on those administrative demands and going through their inbox. And then also rated really high up there is something they wanted to see from their medical groups is more time for self-care and health-related activities. And that's something that we're really striving to do in the Sacramento region through the stuff that we're doing through the Medical Society, but then also things like, for example, that Peter's trying to do with the wellness program here at UC Davis. The other component that really kind of came out in the survey is that doctors really want to connect, and you want to connect with colleagues. You want to network and support each other in a culture of wellness. Back when we started the Joy of Medicine program, I had a physician member that was struggling with some issues and with depression and so on, and was talking to me, and he said, Aileen, if I had a drug problem, there's a group for me. If I had a problem with alcohol, there's a group for me. I'm a high-functioning professional, having a hard time right now. There is nobody for me to talk to. There's now groups for you to be able to go out and talk to. Those are our peer groups that are out there, to be able to connect with other physicians and to be part of that collegiality. And we're hoping to promote that more and create more groups that are convenient to you all to attend. Finally, the component to access competent, convenient, and confidential care. That is something that we are doing through our resiliency sessions that I mentioned. And I will add that one of the things that came out of the survey is, we did find that there was a small number of physicians, but important nevertheless, because it only takes one, that felt that they, or reported that they were so burnt out that they did not know if they could go on. Okay, that scared me. So what we did to kind of address that is we worked with UC Davis and with Peter in the Department of Psychiatry to create a direct access program for not just UC Davis physicians, but for any physician in this community. In private practice, they could be part of Sutter, they could be part of Permanente, we don't care. They have now a direct access to Department of Psychiatry and to the psychiatrists that actually work with physicians on a daily basis for intervention and for referral out. So that's a new part of our program that we have incorporated as well. Peter, I think I am going to stop there, and we have about 6 minutes, and we can open it up for some questions. Anybody have any questions about our services or any things that we're doing? Hello.
Dr. Mel.
I enjoyed your talk.
Yes, you do.
Okay, I have two questions. I really laud your efforts to try and address this issue, but it gives me a little concern that we look at 1 out of 3 physicians with an issue and that's a success. What are organizations like you? 2 questions related. Number 1, give us some historical perspective. How does the burnout, or if you can't measure that, physician suicide rate compare now versus 10, 20, 30 years ago? And what are organizations like yours doing to try and address the root cause of what's going on? Because at the end of the day, I don't think 1 out of 3 is even close to where we really want to be as a profession.
I agree, and I'm going to let Peter address, from the suicide perspective and the changes, that he may see there. But as an organization, I did not mean to promote that as a success. I was pleased that the numbers were what they were, and that physicians weren't at 60, 70, 80%. I think we're on the right track, but we still have a ways to go. 1/3 of physicians that are burnt out is too many. 1 physician that is burnt out is too many. I absolutely agree. So what our program, and again, we're 2.5 years into our program, is to make sure that we're creating that culture of wellness so that nobody's falling through the cracks. So when we get together, when the different CWOs and so on, get together at the Medical Society and kind of brainstorm this through, these are all things that we're struggling with as well. And trying to connect those physicians. There's physicians that probably are not even reaching out. How do we get to them? And some of the answers in that, I know Peter and some of the other leaders have talked about, as colleagues, how do we help identify a colleague that may be having a rough time, and how do you intervene with that person and help to get them into treatment or to help them to get to talk to somebody. But I do agree with you. 1 physician that is feeling burnout is 1 too many. So it's a work in progress for us.
And just briefly, in terms of going forward and the sort of the past data issues, I mean, the reality is we don't know what number of people either were burnt out or depressed or even who suicided. I think the denial of our profession about our own health is so extreme that there's actually been remarkably little research until literally 5 or 10 years ago. The physical health data I quoted, whereby physicians live 2 years longer than average equivalents, that comes from a 2002 Canadian paper that has not been replicated. It's quite remarkable. So any residents or people who want to get involved in research, come and speak to me. There are so many things you can investigate here, but we don't know.
Aileen.
Question for Peter. The data you presented, how does that compare to other countries, specifically, let's say the UK? Because I know they have data.
Yes. So it's interesting. The UK is actually, in terms of collecting data and doing something about it, is actually worse than us. And I can say that as someone from the UK. They're not going down this process of actually developing chief wellness officer or equivalents. They're not looking at major amounts of data. I was actually just had a UK chief medical officer across last week visiting here to see what we were doing. Because they're doing very little there. So having trained in the UK, I mean, the issues are the same.
But they've limited work hours for
But
many
that's
years,
right. Yes. And so there's no doubt that in Britain, if you the aim in Britain is to survive residency and then become an attending. At which stage you're meant to be able to put your feet up a bit more. And look, it is possible to limit work hours. Okay, I mean,
it's worse. It's the other direction.
Right, and it is possible to limit work hours. The best example of that is the Scandinavian countries, whereby attendings hours are limited to 40 hours a week, and that's it. And they still have good surgeons, good physicians. They have good training programs. I mean, you may not like me to say this, but I absolutely believe that we should be markedly reducing resident hours. We should be markedly reducing attending hours. And that it's not, and that time is, or lack of time, is one of the biggest single stressors. And I just do not agree with the fact that we need to have 80-hour weeks for residents as a sort of maximum. I mean, I think that's absurd.
Dr. Ali, and then Dr.
Thank you both very much. Aileen, it's great. I didn't know about any of this, so thank you for telling us. Question goes to really both of you, but it references a conversation that you and I have had in private, Peter, which is right now all of these efforts are based on identification of an individual at risk, right? And that's how you sort of get into the system. I think for us to truly be successful, everyone from day one should have an expectation to be well, right? As an individual and kind of move along that trajectory. I think that's going to be transformational. I think it's going to be challenged by the fact that if you look around this room and you say, shouldn't everybody be well? We'll all do this. But when it comes to really implementing it, we're like, well, I got to get to this page. And I mean, we, by nature, the way that we think is about being in ways that are unwell, right? So how do we get from here to where each person expects every day to do things that makes he or she well? Because if we can do that, then we'll have less people that we need to identify as individuals and be really afraid, like Aileen did when she got that message. Because you're right, that scares the dickens out of me if I would see that.
Mm. Yeah, and I think, it's a very good question. I don't have a good answer, except that we absolutely need cultural change. That's why I put up that slide on professionalism, okay? I'm working with one of our medical students at the moment to see if we can actually change the Hippocratic oath that they take when they qualify, so that it includes some components around self-care and care of their colleagues. Because in the Hippocratic oath, there is nothing on that. It's quite extraordinary when you think about it nowadays. And so it doesn't get into the culture from a very early stage. So to me, this is a big cultural issue. We start off actually very well as a group, and within 10 years we're burnt out, and then it just carries on. So it's clearly, to do with organizational issues and how we're treated, and it's very similar in Britain, having been a resident in Britain. But it's similar in many other countries, but not in all. And so I think my view is we should be taking account of a lot of the Northern European countries, looking at how they organize medicine. They actually have better medical outcomes than we do as well, and they're much cheaper. And so if you're looking for a good way of organizing medicine, go to Northern Europe, because they seem to do a lot better job.
And I would just briefly add on to that. I think you bring up a very good point, and I think one of the things we're striving to do with Joy of Medicine is to create that culture of wellness throughout the Sacramento region and to touch all physicians. And we're still in our infancy, the program's starting, but it's gained a lot of traction, and I think we're on the right track. We don't have the magic pill. There's still going to be folks that we're going to try and catch and bring up. But if we can create some collegiality in the region and have folks feel proud to be a physician and feel respected by your patients and by the health systems you work for, then we're on our way to winning.
Dr. Cook.
So wow, it just appeared out of nowhere.
He's a
Apparition.
ninja.
It's amazing.
Yeah, I want to applaud the health system and the medical society's collective efforts on this subject. I think it's a lot of work, and you put a lot of effort, and it shows that this topic is a topic of importance, at least within this region. I have a quick commentary and then a question. The one commentary is I think the physicians' lounge, or whatever it's determined, that's in the basement or in the first floor of the North Addition, is an underappreciated gesture by the health system. Right. I think a physician's lounge used to be called a doctor's lounge. Is kind of an old-time thing that's found in a lot of older community hospitals, and it was really showed an appreciation from the institution to the individuals who in many ways drive the success and financial livelihood of that institution. And I know it took, about 10 years to get that developed for multiple different reasons, but the fact that it was able to get over the hump is, I think, is a good sign, and is greatly appreciated. The second, the question I have is, you focus a lot on really the high acuity stuff, which is very important. That's suicide, right? And oftentimes in health services research, we look at mortality and how to reduce mortality, and now we've transitioned to other less dire things. One thing I look at is attrition. So people leaving the institution because they're fed up with the institution as opposed to healthcare itself, right? Because they're going to another healthcare institution. Are there departments or programs or centers within UC Davis that you think are doing very well in regards to the health and wellness of their members? And if so, what are the sort of department level or center level strategies that they are implementing?
So I think that's a really crucial question, and I thank you for that. I mean, that's actually why I'm interested in creating this dashboard, which would include things like turnover, because we don't know. I mean, that's a simple answer. I mean, the chairs could probably all get together and sort of do something about what they all thought in terms of turnover. I have genuinely no idea which departments or which areas have the highest turnover. I'm trying to find out. And we actually don't keep sort of data that is very easy to compare. So that's one of the things I'm looking at specifically now. The more important issue, quite honestly, than that is actually people leaving the profession or not going into the profession. And there's study after study of physicians who say they wouldn't want their children to become doctors. And there are increasing numbers of physicians who are leaving and going into do other things, going into business or other sort of areas. And that's also really important because there's only so many clinical hands to go around. And so we have to think about those sorts of issues as well. But so I think this has very major, not just sort of patient care sort of issues. It's clearly also economic. And the physician lounge. I think every time anyone here sees Doug Kirk, would you please thank him? All right, because Doug was phenomenal. Okay, I have argued with the Wellbeing Committee for 10 years now, spoken to every dean, to every senior person here to try and get a physician lounge. In England, we actually called it the doctor's bar. And I was brought up with the doctor's bar. But the physician lounge is a really important sign of the current leadership of the health system's support for physicians. And Doug put a lot of his personal capital into that, so thank him.
I'll be very
I'll
be very brief. 2 points. One, I agree the Physicians Lounge, not only does it have great treats, but on Sunday morning, I was able to look eye to eye with the palliative care doctor, the orthopedic surgeon, and myself, and for a very difficult patient. So we actually made some good progress. But one thing, there was a psychiatrist named Gabbard, Dr. Gabbard. Anyways, he wrote a paper about the personality of the surgeon and why the surgeons in particular might have difficulty with some of these issues, because it's a catch-22. What's good for the patient sometimes isn't so good for the surgeon, because we tend to be very meticulous and type A and perfectionists, and that's fabulous for the patients that we take care of, but that's also not so good for us. So we have to, I think, understand what he pointed out in his article was that we have to kind of understand our personalities and embrace those, or just realize that that's a problem, and not let that be a negative force.
I think that's right, Catherine. In fact, if you look at admissions committees, they actually choose for medical school, for preference, students who are, obsessional and organized, which in my psychiatric world is called compulsive. And they choose people who are caring and want to help everybody, which in my world is dependent. Okay, and so I can look at these people at the types of people we come in, and I know that dependent compulsive people are at actually an increased risk of psychiatric problems.
This one over here.
Residents over here, we just talking about that. We would love that.
We're well aware of that. Okay.
There's a surgery resident lounge in the basement, and there's a surgery resident space that your team is working on developing in the North Addition.
As long as we have Rice Krispie treats.
Residents together is the work in progress, but for the
Right.
surgery folks there are too.
Yeah.
The question I have actually is really all of these. The work hour restrictions and the way the health, the well-being seems to be very generalized. At what point do you go into the individual? So, for instance, not everybody wants to go home at 80 hours. To be honest, some of us, you enjoy being here. Some people like being here 60 hours, but it seems so individual that telling somebody that wants to have blue scrubs that you're required to have green scrubs, or you need to go home at this time, it can be more detrimental to the mental health than.
Sure, and look, everybody's different, and I agree entirely. And look, if you're in academia, and many of us are, we spend a lot of time at home, and other times, working on papers or traveling to conferences or doing all sorts of things. But they're more through our choice at one level. And we've actually, to get away from surgeons for just a second in terms of long hours, we've just done some surveys using Epic to look at how many minutes after hours time PCN physicians spend on the EMR. And there are a substantial number who literally average 15 to 20 hours per week on the EMR outside of all their normal clinic time. Now that's unpaid time. They're not, and it's pure clinical work on the EMR. Now, some of them are doing it because they are compulsive people and they want to get absolutely everything right. Okay, but a lot of them are doing it because they're just desperate to catch up, or perhaps they haven't organized their life as efficiently as they could. So we're all different, and there's no doubt some people are okay working long hours and differently. That's fine, but a lot of people are not.
I think it's interesting. I just came back from part of my son-in-law's sabbatical. So he's an executive with a roofing company, essentially. Right. And every 3 years, they have a 1-month sabbatical, but not like we doctors think of a sabbatical where you're supposed to go do more work. He's not allowed to do work. It's not, and it doesn't count against vacation. And all the executives in the corporation do that. I thought, God, how come the roofers have this figured out?
Yeah.
And we don't. And of course, I came home early because I didn't have the same amount of time to take off.
Yeah.
But it just was a very interesting juxtaposition of how other industries manage stress for their high-functioning people.
Yeah, and I do think as a profession, we're a pretty dependent profession, okay? And a lot of that dependency is our own wanting to feel good and wanting to sort of almost do better than anybody else by working longer. And I actually think that's not a good approach.
Well, thank you very much, the two of you guys.